Hello, everyone, and welcome to the Dr. R Show. We'll be coming to your living rooms weekly to discuss various health topics with the help of medical experts in their respective fields. Meet my two very special assistants, Megan and Christina.
And I am so excited because today is leg day.
And then inhale as you lower back down.
They will be with me every week to give us tips on healthy eating and proper exercise.
Stretch and keep yourself hydrated.
So welcome to my show as we both learn together. Hello and welcome to the Dr. R Show. Today we welcome back Dr. Abrahams, Head of Renal Surgery for Urology Associates of North Texas. Previously we discussed with Dr. Abrahams the kidneys, how they function, and the factors that contribute to kidney stones. Today we'll cover the current treatments for kidney stones and what can be done to prevent them from occurring in the first place. We'll also be discussing treatment of kidney cancer and the surgical techniques, which have come a long way technically from when I first finished my training years ago. Dr. Abrahams, welcome back to the show.
Thank you.
On your previous appearance, we discussed why kidney stones formed. After someone is diagnosed with kidney stones, naturally the next step would be choosing appropriate treatment and preventing stones from forming in the future. How does a urologist decide how he's going to treat a kidney stone once you diagnose one?
Well, it really depends on how big the stone is, where it is, and if there's multiple stones or just a single stone. So if somebody has a small stone that we anticipate might pass on its own, which a lot of stones, say 5 millimeters or smaller, would do, we usually give them medications to help with pain or nausea if they have it. And then we might give them medications such as Flomax, Rapaflo, something like that, what's called alpha blockers, to help them increase the chances of passing it on their own. Also, if they have a uric acid type stone, we might give them medication which actually can dissolve the stone where it is, which obviously would make all the symptoms go away. But for a lot of stones that are either too big to pass, or for a patient who's having too many symptoms trying to pass it, we have to do surgery. And there's basically three main treatment surgical options. The first one is called shockwave lithotripsy, and that's a nice technique invented in the 1980s. Very non-invasive treatment. The patient is sedated, a machine is brought behind their back, and shock waves are delivered, sound waves are delivered through their skin to the kidney stone, which breaks it up into tiny little particles, and they pass those over the next few days.
Now, any damage to the kidney from these shock waves? Because it's sitting and pounding on it. Does it bruise it at all, damage it in any way?
Actually, the incidence of bruising or damage is extremely low. It turns out it's a very, very safe way to deliver energy to kidney stones through the kidney. There are rare times when that can happen, but that's very, very infrequent. It's actually a very nice treatment considering it's non-invasive. Overall, about 85% successful in the right patients. So it's actually a very, very nice non-invasive treatment.
Any complications from that at all?
Well, the biggest complication would be the potential if the stone is too dense, if it doesn't break up well, or if it breaks up well but the pieces get stuck in the narrow ureter tube on the way out. And that's when we have to go to the next option, which would usually be what we call laser lithotripsy. So in that technique, we use a very small diameter but very long telescope, such as what we have here, and we put it inside the person's urinary tract while they're asleep, and we have the ability to bend around the different corners and use either a wire basket to pull out fragments or stones, and we have a tiny little laser device that can go in there and break up stones no matter how hard they are. So this is a very nice treatment. It's a little bit more invasive than the shockwave, but has an even higher success rate because we can go to different parts of the stones, and it doesn't matter how dense the stone is, we can break it up with the laser.
How do you know how to navigate it in the kidney?
We use real-time X-ray, what's called fluoroscopy, while we're in there. So we actually are looking under X-ray to see exactly where we are, and then once we hook the scope up to a monitor, we can actually see exactly where we are in the kidney.
And then in the final analysis, you can actually see the stone through this instrument.
That's right. We're actually watching it on a computer screen, and so we can see exactly where we are in relation to the rest of the kidney.
And then once you see it, what do you do with it?
Well, small fragments we would pull out with a tiny little wire basket that goes right through here. We're talking about instruments that are less than a millimeter in size now. Or we have a laser fiber that's about 1/3 to 1/5 of a millimeter in size that can go through the scope and actually deliver very, very high energy light waves right to the stone to break it up into tiny fragments.
Now, do you have to touch the stone with the laser, or does the light itself do it?
Actually, you have to touch the stone to the laser because one of the things that makes this particular laser very safe is that it does not transmit through water. So that's what makes it safe for the kidney. But the stone has to actually touch the laser fiber, and that's why you have to have a scope that can make bends around different corners, because it does have to actually touch it.
Now, how effective is this particular treatment? Are there failures even with this?
There can be failures. The one limitation, the two limitations of this technology is, number one, you have to be able to see. So if it's too bloody or the tissue is too swollen, sometimes you wouldn't be able to see. And number two, the laser, like we said, has to touch the stone. So for example, if you have a stone that's way down or the kidney anatomy is altered, you might not be able to reach it, and you might have to do some other type of technology.
So if this fails, what's your next step?
Well, if this technology fails or somebody has too much stone to do that way, we do a surgery that's called percutaneous, which means through the skin, nephrolithotomy, which means breaking up stones. So if, for example, we can't get to it in another way, we actually make a small opening right into the kidney, right through the back, and we insert a scope that kind of looks like this. We're watching through the video that's hooked up to that, and we can actually break up stones and grasp pieces. The advantage of this is, since we're not going through the very narrow diameter ureter tube, we can actually take out much larger fragments. It's much, much more efficient because the devices to break up the stones are much, much more powerful.
Now let's talk about prevention. How do we prevent stones? How do we keep them from forming in the first place once you diagnosed it?
Well, the first thing that we need is a piece of a prior stone. That's very, very helpful to find out what type of stones they have. If they have uric acid stones, which is about 15% of the population, those we can prevent with medication. Everybody else typically has calcium-based stones. Those there's no medication to prevent those. So what we need to do is analyze the chemistry of their urine and see what the exact problem is that's forming the stones. Number one, most people don't drink anywhere near enough fluids, especially people that live in the South. Because it's very warm, you got to drink a lot more fluids. So we analyze how much fluid they take in, how much fluid they put out, and therefore we make recommendations. Typical recommendation is that a stone former needs about 100 ounces of fluid intake in 24 hours to get about 80 ounces of urine out. That's a nice statistical number whereby we see that the urine is dilute enough to not make more stones. Some people, it's not the fluids. Some people, it's what they eat. So a lot of us eat way too much sodium, and the sodium increases calcium in the urine through a little pump in the kidney anatomy, and therefore people who eat a lot of salt will make more kidney stones, so therefore we put them on a low-salt diet. And then there's some more rare type of stones where we do give them other medications and things like that. And there's a few other dietary recommendations that we make, sometimes around protein, sometimes around oxalate-containing foods, which is like spinach and pepper, chocolate, iced tea, those kinds of things. So prevention is mostly with fluid management, dietary management, and occasionally medications.
And now for a short break. When we come back, we'll talk with Dr. Abrahams about kidney cancer and the novel ways it is currently treated. Stay right there.
Hey guys, we're here at Inside Fitness. I'm Megan and this is Christina, and today we're going to talk about the core. You want to always have your body ready for the beach, so we're going to show you a few quick core workouts. Now the core is very important in your posture, your everyday activities, and just stabilizing your body. So Christina's going to show you some awesome core workouts.
Right, so I'm going to take you through a variation core workout that you can do anywhere, anytime. It's quick, it's easy. Well, I won't say easy, but it's quick. So Megan's going to do the modified version, and I'm going to do the advanced version. So what we want to start out doing is go ahead and lay on your back. Okay, so keep that lower back on the floor and really engage those lower abdominal muscles. What you want to do is lift your legs into the air. Megan's going to lift hers at a 90-degree angle. I'm going to lift mine straight. And then we're going to slowly lower down until we get about 1 inch off the floor. Hold, and then pull back up again. Once again, you're wanting to make sure to keep that lower back on the floor and really engage those lower abdominal muscles. You're going to do this about 10 times, and when you're done, I want you to engage your chest. Go ahead and look up at your feet, and we're going to do the scissor kick, side to side. You want to do this about 10 times and then immediately switch into the flutter kick. All right. Do that about 10 times. Go ahead and sit up, and then we're going to grab our medicine ball or whatever heavy object you might have. So I'm going to lift my legs off the floor, and Megan, you're just going to keep yours right there on the floor like that. We're going to go to the side for 1, other side for 2. as we're doing this, I want you to notice how Megan's really engaging those oblique muscles here on the side of her abdomen. She's really doing that, and she's kind of keeping most of her body forward and just really twisting at the abdomen, so make sure you're doing that. All right, and that's it. Now we're ready for a stretch.
Hey everyone, I'm Megan and this is Christina, and today we're talking about fats. You've probably heard of the different types of fats like saturated, unsaturated, and trans fat, but do you know which ones are the healthy fats and which ones are the unhealthy fats? An adequate intake of fat is necessary for optimum health, so eating fat is not the problem, but eating the wrong types of fat is the problem. So the fats you want to avoid are the trans fats and the saturated fats, which can contribute to clogged arteries, increase your risk for heart disease, and increase your total cholesterol and your LDL or bad cholesterol. And also when you're looking at the food labels, keep an eye out for the term partially hydrogenated, because that also means trans fat. Now the good fats that we're going to get from our meal today are the healthy unsaturated fats, and these are found in olive and sesame oils, nuts, some seafood, and from today's meal it's going to come from the avocado. So we're going to put together some avocado egg salad lettuce wraps, which is a great breakfast to have in order to get some of those healthy fats into your diet. So we're going to grab some lettuce.
Here you go. Thank you.
Half of a ripe avocado.
Perfect.
About a quarter cup of cucumber, and about a half a stalk of a green onion. So Christina, go ahead and cut up the eggs and then you can place them in this bowl.
Alrighty.
And then we'll just get some lettuce on the plate. We're going to actually wrap the egg salad inside of the lettuce.
So this is probably something like a tuna salad or like a chicken salad, but just lacking some of that heavier meat.
Exactly, and you actually can add some lean ground turkey to this if you wanted to get some meat in.
Okay. I love the way avocado tastes this. All right,
And that's
let's
kind of
just
the
set
replacement for the mayo, a little bit healthier of an option. And then we'll add a little bit of salt and pepper to taste. So now you can add about a teaspoon of lemon juice, or you can use red wine vinegar. And we'll add the green onion,
Yum.
some cucumber.
And if you don't really like cucumber, you could use zucchini as a replacement. It's
Yes,
kind of
you
that
could.
same consistency.
And we'll get our avocado. Now the unsaturated fat that's coming from the avocado can actually help increase your HDL cholesterol or your good cholesterol, and it is heart healthy. Okay. And if you want to go ahead and mix that up for me.
Alrighty. Some of the things that you can do is also pre-cut your avocado.
Just cut it up.
Cut it up.
Smells good.
I wonder if you could even use like an all-natural guacamole.
Probably.
Okay. So Megan, after we go ahead and mix all of this up, what's next?
So now all we do is scoop it onto the lettuce, just wrap it up like a sandwich, and you're good to go.
Okay.
And the lettuce is actually replacing the bread.
That's perfect. You know, you could probably do this with anything that you wanted to make into a sandwich, right?
Mm-hmm.
But this is great because you've got your egg whites, you've got the middle of the egg, so you're getting a lot of protein, and then you have all of those good fats in the avocado. Voila! So this is something really easy that you can make out of the fridge without having to do any cooking at all, and it's an excellent snack or a great meal replacement.
Welcome back to the Dr. R Show. We're here again with Dr. Mitch Abrahams, who specializes in complex kidney surgeries. Welcome back, Dr. Abrahams. Now let's switch gears and talk about kidney cancer. What is kidney cancer?
Well, kidney cancer is a tumor that develops in the kidneys. When a tumor forms, basically the cells that were supposed to be there get the wrong signal, and they keep making more and more and more cells until an actual three-dimensional tumor is developed that gets in the way of the normal kidney function.
And how many types are there?
Well, there's two main types of kidney cancer. One is cancer of the so-called parenchyma, what you might think of as the meat of the kidney. That's where actually all the cellular work is done that makes the urine. And that's what we call renal cell cancer. That's the far more common type of kidney cancer. And then you can also get cancer of the urinary tract of the kidney. That's called transitional cell cancer. So those are the two main types.
And which of the two is more aggressive?
Well, it actually turns out that the less common, the transitional cancers, is more aggressive. That's the cancers of the urinary tract. So for those, we have to be much more aggressive in our treatment to make sure that we eradicate it.
And how common is kidney cancer?
Actually, kidney cancer is not one of the most common cancers, not like breast or prostate, but it's fairly common in the next sort of tier of incidences. In the United States, about 60,000 people will get kidney cancer in 2015, approximately, and about 14,000 of those people will die from kidney cancer. So you can see from the statistics that most people who get it are treated in a way that they survive long term. It's highly treatable cancer.
And that's both renal cell and transitional.
Those are the numbers for the renal cell cancers. Transitional cancers, probably about 20% of those numbers, so it's a much more less common cancer.
Now, what are the risk factors? Who's getting kidney cancer?
Well, kidney cancer is mostly a disease of people in their late 50s, 60s, and early 70s, although unfortunately we're seeing more and more younger people with it, and that is not clear why that is. There's not a lot of risk factors that have been exactly worked out, but there is a connection with people who smoke or were exposed to smoke, and there is a connection with people who are obese. But other than that, the far majority of our patients don't fall into those categories, and so it's not clear why they developed it. Transitional cancer, which is the cancer of the urinary tract, very, very strong relation to smoking. A lot of those patients are smokers or were exposed to smokers. And also people who work in industries with benzene, dyes, and things like that.
What are the signs and symptoms? How does somebody know they have kidney cancer?
Well, most of the patients we see now that have kidney cancer actually have no symptoms. A lot of these patients are picked up because they get an x-ray for some other symptom. Maybe they had a tummy pain one day or some nausea and their doctor ordered a scan and we found it what we call incidentally. So for renal cell cancers, that's the most common presentation. Second to that, people might have some blood in their urine, either that they can see or that their doctor can pick up on screening tests. Definitely for urinary tract tumors, blood in the urine is the #1 way that those are picked up.
And how do you stage a cancer? I understand there's different stages to kidney cancer.
Sure. So let's split up the two main types of kidney cancer. So when we're talking about renal cancers, that's the ones that are in the meat of the kidney. Most of the patients are stage 1. And a stage 1 tumor is any tumor that's contained in the kidney that's less than 7 centimeters. So that's about 3 inches roughly. So it goes by size. Stage 2 tumors for that type of cancer are ones that are bigger than 7 centimeters, but still contained in the kidney. Stage 3 disease is when it has invaded into the tissue next to the kidney. So that would be the fatty protective layers of the kidney or the major blood vessels near the kidney. And then stage 4 is if it goes into an organ next to that. So if it goes into the adrenal gland or the intestinal tract, pancreas, spleen, liver, anything like that, that's stage 4 disease. Now, the transitional cancers, which is the urinary tract cancers, those are staged based on the depth that they go, so not the size. So stage A disease is actually just on the surface of the urinary tract. Stage 1 is a little bit deeper into the wall of the urinary tract. Stage 2 is in the muscle underneath the wall of the urinary tract. Stage 3 is when it goes actually into the kidney, so it actually invades through the wall of the urinary tract into the kidney. And then stage 4 would be if it went into something nearby.
So for renal cell kidney cancer, what are the treatment options? How do you treat that?
Well, the #1 treatment we do now in our center is what we call robotic partial nephrectomy. So basically, this technology came out in the late 1990s, but wasn't really widespread used for kidneys until about the last 5 to 7 years. And basically what we can do with most patients is through very, very small incisions under an anesthetic, of course, we go in and actually cut out the cancerous part of the kidney and reconstruct the good parts of the kidney. So we sew together the urinary tract, we sew together the blood vessels that need to be closed up, and the outside of the kidney. And we do all that all through little teeny tiny incisions using the Da Vinci robot. That's our #1 treatment now. Now, if you have a larger tumor, or a tumor that we think is invading, then we usually do telescopic surgery to remove the entire kidney. That's called laparoscopic nephrectomy. Very, very uncommon, but still occasionally needed. Some people have to get chemotherapy. Some people have to get what's called immunotherapy, medicine to boost your immune system to fight the disease. That's for people who have disease that has spread other places in their body, or for people who can't have surgery to cure them. And then even more rare than that would be radiation. Say, for example, kidney cancer that goes to the bone or goes to the brain or something like that. They'll be treated with 3D radiation therapy. Now, that's for renal cell cancers. Transitional cell cancers, almost all of those patients will require full kidney and ureter tube removal. It's actually kind of 2 operations in one. We do those robotically and laparoscopically as well. A very rare potential for those patients, if they had a really small superficial tumor, would be for us to use a similar ureteroscope, like we showed for the stone disease, to laser the tumor. That would be mostly if they had a very, very small tumor, or if they only had one kidney, say the other kidney had been lost to some other disease, we might have to use that.
Great information, Doctor, and thank you for being on the show. And thank you for watching this edition of the Dr. R Show. Until next time, healthy living and goodbye.